So when we think about movement disorders, I think those of us that have been working with older adults for a long time, we think, oh, it's Parkinson. But you know what? It's not always Parkinson. Okay, so if you take away one pearl from me today, just because the person has a tremor doesn't necessarily mean it's going to be Parkinson. We're going to see a lot of Parkinson disease, but it's not always going to be Parkinson. All right, so when we think about movement disorders, you know, we can classify them into one of two buckets, okay? Either not enough movement, and that's called hypokinesia, and that's Parkinson's disease, okay? And that's Parkinsonism, Parkinson plus syndromes, and those are some things that look like Parkinson, but when we give them a trial of Sinemet, levodopa, carbidopa, they just don't respond as we would think. And then there's too much going on, hyperkinesia, right? So that's what you would see with the person who has Huntington, some dyskinesias, dystonias, and some of the other tremor syndromes. So one of two buckets is that's how I kind of think about it in my mind's eye. Okay, so I wanted to start off with 3 cases, and of course this is not the real picture of these individuals and the names have been changed, but they are really true cases that I've seen in my practice, and all 3 of these individuals were very, very dear to me, and I actually learned a lot as an NP. So our first case, and we'll come back and talk about these towards the end. Our first case is Clara, 76-year-old lady. She came in just for a routine recheck. Really was a fairly healthy individual. She had high blood pressure, she had high cholesterol, just in for a routine evaluation of her chronic medical problems. So she was really funny because she always called me little girl. So, you know, so I was doing her exam and I looked over to the side of the room and I saw a cane. And I said, Clara, what's the deal? And she said, it's a cane. And I said, well, I know it's a cane, but you don't ever have a cane. And she said, well, I'm OLD. I said, well, you were old last time you were here, but you didn't have a cane. So what happened? And she said, well, I fell. I said, well, okay, well, what happened? She said, girl, she always called me little girl. She said, girl, I fell back. And I thought, Okay, so that's our first patient. So our second patient is Jim. So Jim, I had been seeing him for many years in our clinical practice. Lovely, lovely man, a lot of medical problems, hypertension, high cholesterol, he had coronary disease, he had peripheral arterial occlusive disease of his legs, and he had this lovely little wife, and I can't remember, her name started with an M, so let's call her Martha. So they'd been married for years, met in high school, had grown kids, they were just the cutest thing. So Martha didn't drive, but Jim was retired, of course, so he drove Martha everywhere. All right, so he came in to see me, and I noticed a little bit of a resting tremor. He was right-handed, in right hand dominant. So I noticed a little bit of a resting tremor, and I did a musculoskeletal exam, and his gait looked okay, and he didn't have any rigidity of the extremities. And so about a month after he was in for his regular visit, the wife calls, and she told the nurse, I need to talk to Dr. Patty right away. So, of course, I'm from Dallas, and so I get on the phone, and I said, you know, Miss Martha, what's wrong? And she said, well, Dr. Patty, Jim went to get gas, and I got a call from the gas station in Houston. Not good. Okay, that's the second case. Third case is Edward. So Edward was a new patient to me. Somebody in his Sunday school class came to our office. So, you know, he came in and he said, I know I'm old, but I'm slow and I'm weak, okay? And I'd never seen the man before. He really was a fairly healthy man. I think he took a vitamin. So he didn't have a lot of medical problems that were known. And so when I assessed this man, he had cogwheel rigidity, he had trouble getting up out of a chair, and he had a shuffling gait. Okay, so those are our 3 cases, and we're going to now talk some about tremor, and then we're going to go back and talk about these folks at the end and kind of think through, you know, what could be going on here. Okay, so in terms of movement disorders, you've got Parkinson, and then you've got atypical Parkinsonism. So those are the things that kind of look like Parkinson, but they're not, and they're not going to have the same response to carbidopa, levodopa. And then you've got hereditary or essential tremor. Okay, so let's talk about some of these Parkinsonism types of scenarios. So MSA, multiple system atrophy. So there's different presentations of this. The most common one is Shy-Dragar syndrome. So I tell my students, this is the Johnny Cash disease. Okay, everybody knows Johnny Cash if you're from the South, and he was a famous country western singer. And he developed Shy-Dragar disease in his 7th decade of life. Okay, so what happens here is the person has what looks like Parkinson's, but they also have very pronounced autonomic failure. So these people, they stand up, they have no blood pressure, and that's early on in the trajectory of the disease. Where in idiopathic Parkinson's, we're going to see some orthostatic hypotension, but not from the get-go. Okay, so that's kind of like mid part of the disease. And they also have some cerebellar dysfunction, so they can have some nystagmus and some ataxia and things like that. But the real thing here is this disabling orthostasis early on, and that's oftentimes what brings them in to be seen by a healthcare provider. So levodopa may do a little bit early on, but for the most part it doesn't do much, and they're profoundly orthostatic, and we have to think about, you know, treating that orthostasis very early on in the trajectory. Okay, so the next Parkinsonism to be aware of is PSP, progressive supranuclear palsy. One of the neurologists that I had the pleasure of working with for many, many decades, he said, the way to remember this, Parkinson's with funny eyes. Okay, so they have a dysfunction of their vertical gaze. Okay, so early on, their EOMs are not intact. So it is important to always assess the extraocular muscle movements when you see a person with tremor. That's just something you got to remember, because if you see enough older adults with tremor, you're going to see a case of PSP. Now, there was an actor, he was also a singer and a pianist, Dudley Moore. And he had a famous movie with Bo Derek. That's what put her on the Hollywood screen. It was called Arthur. And he developed PSP when he was in his, I believe, late 50s. And so this is a very progressive type of movement disorder. So they have an akinetic, so they're very, not just slow movement, but they can't move at all. And they lose their balance early on. Many, many falls early on in the disease. These people get incapacitated very, very quickly, and usually they pass away from this disease within 6 years. So it is a rapidly progressing type of movement disorder. Okay, chorea. And there are many different types of chorea. Huntington's disease is probably the most common cause, but it could be from drugs, from a stroke. There is such a thing as senile chorea. I've only seen one case in 20 plus years. And we don't have a lot of really good treatments for chorea. We have some dopamine receptor blockers, don't work too much, and their side effects. And then there are some FDA-approved medicines for Huntington's, and there is a new drug on the market that it's not approved for this, but may be tried. Brand name is Ingrezza. Okay, not approved for this, but may be used because it's very chemically similar to tetrabenzene and deuterabenzamine. Okay, dystonia. This is a hyperkinetic movement disorder, so there's prolonged muscle contractions, and it could be inherited or isolated or part of some other type of movement disorder. So the common dystonias, probably the most common, there's two common ones, spastic torticollis, so they get this kind of thing going on in their neck, or blepharospasm, okay? Spastic dysphonia can also be seen. I had two great aunts. They were both registered nurses. They both had spastic dysphonia and torticollis, but that's all they had. They didn't have any other type of movement disorder. So we will think about meds, some of the older anticholinergics, but again, you have to really weigh risk-benefit. Baclofen can be used, but botulinum toxin is what is really used and very, very effective for dystonias. That's not drug-related. Okay, and then drug-induced movement disorders, and of course we all know well the main family of drugs that can do that, your older antipsychotics, but your newer ones can also do it. Exceptions, quetiapine, and clozapine. Then pimavanserin, brand name Nuplazid, also is one that cannot cause movement disorders.